Hi, I think now the video.
Hello. Yes, now it works. Apologies for that last minute technical difficulties.
My background is mirroring, right? I see everything. Yeah, that's better.
So Purvi, maybe you would like to try your slides?
Yeah, okay.
And
can you see my slides?
not yet. Loading.
Great. So I think we can get started today. So thank you everyone for joining today's webinar. So this webinar is put together as part of the learning series. And so as part of SKPA-2, which I think some of you may be familiar with, is the sustainability of HIV services for key populations in Southeast Asia. So it's a 3-year Global Fund grant led by AFAO, as well as we have regional SRs, APCOM, Achieve, as well as ICWP. And then also we have 4 country lead SRs in Mongolia, the Philippines, Sri Lanka, as well as Bhutan. And overall, the SKPA-2 program works to improve sustainability of evidence-informed priority HIV services for key populations. But there's also a strong regional focus of this program in order to ensure collaboration with different HIV key stakeholders across Asia, but then also globally. And so as part of this, the SKPA-2 program, we have the learning series. And so learning and development is a central aspect of SKPA-2 program, trying to capitalize on the range of knowledge and expertise across our subrecipients and partners. And we really hope to promote learning to ensure that national HIV programs are grounded in technical best practice, as well as learning from key stakeholders who are experts across the region. And so as part of the SKPA-2, as part of the learning series, which is currently hosted as part of SKPA-2, we've held some webinars already around HIV self-testing, as well as social contracting mechanisms for key population HIV services. And we'll also have other ones down the line, as well as some technical briefs to help facilitate learning as part of this process. And today we have a webinar focused on virtual interventions and best practices. And so in terms of the objectives today is really to provide examples of best practice and innovation in virtual interventions for HIV programming, to increase awareness and evidence of international best practice, and facilitate a dialogue between key stakeholders. And as you'll see, we have a number of panelists from across the region. And so maybe I'll pause here just to allow everyone to introduce themselves, and then I can go over the agenda a bit today. So my name is Matthew Kuzin. I'm the Senior Technical Officer for M&E with SKPA-2 based in Bangkok, housed with AFAO. Maybe Mike, hand over to you for introduction.
Oh, hello, colleagues. My name is Mike Merrigan. I'm the Technical Director for the SKPA-2 project based in Australia. Nice to meet you today. Maybe I should pass on to Purvi.
Good morning, everyone. My name is Purvi Shah. I'm with UNAIDS and WHO, and I support countries on testing and virtual interventions. Thank you, and very nice to meet you all. I'll pass it to Srinivas.
Hi, thanks, Purvi, and hi, Mike. Thanks to the APCOM team and everyone for this opportunity. I am Srinivas, and I work in India with PATH India. We run CDC India's flagship project for HIV prevention in the northeastern states of India. And in Mumbai, I am the technical lead for prevention. And our key work is looking at the first 95 where virtual interventions play an important part. And we've been running virtual interventions programs in India for many times now, many years now. Purvi has been one of the leading ladies there. And so I'll be sharing a few of our experiences from PATH and the previous work that's happened in India. Thank you. I think Nikki or someone, over to you.
Okay, so hello, my name is Nikki. I'm originally from Indonesia. I work currently with APCOM. My current position is Knowledge Management and Learning Officer. I'll be facilitating today's panel discussion. We're gonna have a good, relaxing, and informative panel discussion today. So it's really excited. So let me pass it to Steph.
Hello, everyone. I'm Stephanie Opari, they, them pronouns. I'm the Equality Outreach Manager over at Grindr and working specifically in the social justice program, Grindr for Equality. Lovely to be in community with you all today. I think last is Indanil.
Hi, I am Indonesian Nayaka, Heart to Heart Organization Sri Lanka, as the outreach coordinator.
Great, and we also have Ms. Pamela, who will be doing some interpretation for Sinhala to English during the panel discussion later today. So in terms of the agenda today, we'll start off with a presentation from Purvisha, and she'll walk us through some of the technical best practice and policy guidelines around virtual interventions from the perspective of UNAIDS as well as WHO. After that, we'll have Nikki facilitate a panel discussion with all of our panelists here to talk and run through some different questions with the panelists around their experience with virtual interventions. And Nikki will introduce and go into that session a bit more details later on. And then we'll have some closing remarks from Mike Merrigan from AFAO around where to go from here and how to take this work forward. There seems to be some maybe technical difficulties with the chat. And so if the chat is currently disabled, feel free to type your questions to myself or Nikki directly if there's some technical difficulties, and we can maybe flag these during the panel discussion or during the Q&A later on. So I will hand over now to Purvi to jump us with the first presentation. Thank you.
Thank you so much, Matthew. And I'm just going to go quickly through my slides because I want to leave more time for discussion. So as Matthew explained, while we discussed the SKPA program, I think over the last few years, we've been discussing virtual interventions in our SKPA countries. But a lot of gaps, we've been able to see a lot of gaps in these countries in terms of information about virtual interventions, policy gaps, implementation gaps. And we thought that this webinar would be a good way to kind of kickstart discussions with our countries about what virtual interventions are and what are the policy and guidance that is available through WHO, UNAIDS, and how can we help. So just as a background, we've seen that a lot of people understand virtual interventions very differently. A lot of people call them digital interventions, online. Some call them, some mention that it is only something that can be done with the help of internet, and it is only to do with digital data. But it's actually a combination of all these, and that is why we as WHO and UNAIDS have termed it as virtual interventions, because we feel that any kind of interventions that we use in terms of the HIV program, where we don't expect the client to come face-to-face to a facility, can be termed as virtual interventions. Now, this can be various things. It could be simple awareness over the phone. It could be social media posts. It could be demand creation like advertising or just simply talking to somebody, or even like a ordering and a mailing of a HIV self-test kit. All of this comprises of virtual interventions, and it does not necessarily have to be only internet-based. It could be phone-based as well. With experiences of COVID-19, we saw that a lot of HIV programs were struggling and looking for ways to mitigate the impact that COVID had on our programs. And I think that virtual interventions actually helped programs continue providing services to the populations without actually having to come to the facility. So in terms of target population, a lot of times I get this question during webinars that who is the target population? Can we reach everybody through virtual interventions, or is it like a special strategy to reach specific forms of populations? And I always say that, any kind of virtual intervention should always run alongside the physical outreach or physical program that you've been doing. It is not that we want to replace what you're already doing. It is something that we want to supplement with. just so that we are able to reach out to all the populations that we've not reached so far. And so, this circle actually shows you all the different kinds of combinations of people that we can reach. So this is divided into 3 parts. One is the client characteristics, the other is subpopulation. How can you reach them? So, you can look at all types of people with different kinds of risk behaviors, all types of people with different sexualities, and also give them a choice of how do they want to be reached, whether it is face-to-face or they want to be reached virtually. And so, the answer to this is that the target population for virtual interventions can be anybody who does not wish to come to a facility for any reason. It could be stigma, discrimination, or mere lack of time. Or it could be people who have access to a phone. It need not be internet, but just a simple feature phone would also do. We also looked into a lot of information in terms of, why do populations not access services? Like every program, every country have gaps in terms of their reach, in terms of 95, 95, 95. And we realized that people don't access services. Now, there were various reasons that we could list out. This is not everything. This is just a few things that we could think of. So lack of information and awareness as to where to access services is definitely a gap. A lot of populations think that they are not under risk behavior. They are just having casual sex. They are not having paid sex, and so they are not at risk. Stigma discrimination is definitely still a major barrier of what stops people from accessing services. There's also a lack of options for accessing services. For example, we only have a fixed idea of how people can access services. We give them information through a peer and then bring them to a facility for services. We do not often offer a bouquet of services depending on how and what the person wants to do in terms of access to services. Lack of confidentiality is always a fear that we have amongst our communities, and that needs to be, dealt with in a way. We also have come across this term now, which is the non-identifying populations. These are basically populations on social media or dating apps where they don't necessarily identify themselves as MSM, TG, sex workers, or PWIDs. They want to be fluid. They don't want to bracket themselves into one particular category. And so they are known as non-identifying populations. And they are often missed by our programs because we only reach out to populations who identify their sexuality, because we have a lot of questions to ask them in terms of what is their sexuality and various questions on risk behavior. But people who do not answer those questions or are fearing answering those questions are often missed by our program. And that's exactly are the people who we need to reach out to, because they're equally vulnerable and in need of services. So specifically coming to gaps in testing, we know that non-identifying populations often do not want to visit facilities. They want to access services confidentially in their privacy. And so this is definitely a gap. We are missing out on a huge population, especially on social media, that has not been under the realm of physical program as yet. Not testing the most at-risk populations, we often get into the habit of testing our cohorts repeatedly. We go on testing the same population. They might be at lower risk or have already undergone a behavior change of wearing condoms or using PrEP or getting tested regularly. But we are not looking at newer populations than never tested populations. We are missing the people that don't want to visit a facility, and of course, stigma and discrimination is again a barrier for testing as well. There are also a lot of gaps that we've seen in terms of demand creation. So we know that now demand creation is often done online or digitally. It saves money. We reach a larger population, and communication is easier through social media and dating apps. But what are the gaps? What is the thing that we are going wrong? We often see that there are lack of resources. Like, again, programs have this misconception that digital demand creation or virtual demand creation is very expensive. Advertising is extremely expensive. And so we only have resources where we can print a few posters and, probably do some awareness sessions, etc. It is often not a priority for the health program. Demand creation is often the last thing that people think of. They often think of targets. It's mostly target driven. Programs are mostly target driven and not demand driven. So we often miss out on the demand creation aspect of programming. Not reaching the right people with the right messaging. This is a very common mistake that we often do. We create posts, or our outreach workers start communicating on social media and dating apps, but we are often not reaching the right population with the correct message. They are either very wordy, they are very the messaging is not right, there is no call to action. There are various issues that we see under demand creation and the posts that we see online. Also, very few organizations use technology. We are still looking at programs where we have printed posters and flip charts and things like that. So these are some of the gaps in demand creation as well. So I just wanted to give a few tips on, how do we really create demand? There are any program that you want to start or any new thing that we want to start, we need to take risks, we need to innovate. And the most important part of this exercise would be to listen to the populations that we are going to target, or our target audiences, and learn from them as to what their needs are, what are their preferences to be reached, what works and what does not work in the community, and then test these content pieces with the populations also until you get them right. Unless and until you do this or you go through this journey, we are going to have a miss at the entire campaign that we create. Probably we'll never be able to, get those people to access services. I just had a few best practices to share in terms of virtual interventions. This is an example from India that we did about 4 or 5 years back. It's called density mapping. We used Grindr as an application, and we had some people log into Grindr and just count the number of active users on Grindr at a particular day and a particular time in the day. Not going into any personal details or identifying people, but just merely counting the number of active users at that point of time. And we created a density map to see what were the areas. This is a city in India called Mumbai. And we just tried to map what are the denser areas and what are the areas in which the maximum number of people were active at a point of time. And the outreach workers use those times to actually log in and become a resource on Grindr for people who needed services. This is another example of online ordering of self-test kits along with PrEP. So this was done in Vietnam, where OraQuick was offered online as a self-test kit, where you could order the kit, you could get yourself tested. If you are negative, with doctor consultation, again virtually, you could order your PrEP as well. And this was seen to have a great impact because a lot of people actually got on to PrEP at this particular period of time. And now Vietnam has also scaled up this service across the country. We also have a good example here in terms of how the delivery was planned. So they used Grab Express, which is primarily a food delivery app, to also deliver commodities like PrEP and self-testing kit. This is an example again from India where we tried social network-based approach on the virtual platforms. So we gave out virtual e-coupons to high-risk populations, and then we moved into their unknown networks. And we saw a very high positivity for HIV as well as syphilis. Virtual case management is something that, as programs, we should all start doing. This basically makes use of a phone or a simple device like a computer. It need not need any high-end smartphones. And a case manager or an outreach worker can actually follow up with the client on their journey. So if they need any reminders, if there's a follow-up happening, if they are due for testing, if they need a PrEP refill or an ART refill, if they want to order a kit, if they want to report back anything, if they want to have a doctor consultation, all of this is possible through virtual case management, also known as telehealth now. This is an example from Nepal, specifically during the COVID-19 period, where we saw various phases of lockdowns. And we saw that the PLHIVs were the ones that struggled the most because a lot of people were running out of medication and we wanted them to get on medication and continue providing services to those people. And so a program in Nepal actually used virtual interventions to bring people on virtual support and continued providing services to them during lockdown specifically. Peer champions and case managers actually tracked all these people, brought them on, to a phone call, identified their need in terms of medication or counseling, and then delivered that to their homes since the facilities were not open. This is an influencer video from Indonesia. She's called Cat Womanizer. She only developed a very simple video to show how easy it is to access a website online to book an appointment for an HIV test and go in and get tested without any stigma and discrimination. It was just to show her followers, how easy it was to use virtual interventions and go and get tested without having to disclose any further information. These are some examples of social media advertising that we had done. This was in Kenya. The campaign was called I Am 1 in 3. It was a statistic that we found in Kenya, which said that only 1 in 3 people knew their HIV status, and we used that as a campaign idea. And we kind of motivated people to join the campaign to say that get tested and become that 1 in 3. It was a very successful campaign, and we got a lot of people asking for support, a lot of people who accessed services during the campaign period. These are also some other advertising, that we had tried. There's Google search engine optimization, there's Instagram, there's banner ads on Grindr as well. And some other examples that I found very useful, which gives out direct messages. It's not very wordy. The illustrations are very simple, but it helps in getting the message across to people. So I would like to explain a few key considerations when you're trying to implement virtual interventions. Cost is, of course, one important factor. You do need to budget virtual interventions in your grants or in your national programs. It's not too cost heavy if planned well, but it does require a little bit of an initial cost that you might need to invest in to be able to continue virtual interventions for your program. Your outreach workers need the skill to start communicating with people online. It's a little different from people from outreach offline, and so that skill needs to be updated. You need to keep innovating new things. It might work, it might not work, but please continue to innovate so that you are able to see and try out new things. Stewardship, of course, is extremely important. Ownership from the national program, from the grants that exist in your country, needs to be integrated with virtual intervention so that we are not running this as a parallel program, but rather a sustainable program. We also launched a policy brief on virtual interventions last year. This was in response to HIV, STIs, and viral hepatitis, and it was mainly to help programs and government to plan and implement virtual interventions. We wanted to help people to adapt to various approaches, implementation frameworks that are available in this policy brief, which will be very useful if you want to scale up or implement virtual interventions. It helps you, what does it include? We've tried to include how do you define priority population. We have examples of approaches. We have steps for implementation. We have some security and safety considerations. And we also have information for, where can you reach us for technical assistance. There is an example of an implementation framework, which primarily says that virtual interventions needs to be implemented across the cascade. It's not just for testing, not just for prevention, but rather starts from prevention and ends at viral suppression. And so there are various approaches that can be done virtually. In fact, everything that you do offline can be done virtually if well planned, and then you can take the client across the journey through virtual interventions as well. Thank you very much, and I'm open for questions during the Q&A or the panel discussion, and thank you for your time. Over to you.
Great. Maybe we can pause for. Great. Thank you so much, Purvi. Maybe we can pause for a few questions that we have in the Q&A. Are you able to see the Q&A by any chance? If you're not, I can read them out loud.
No, now I can.
You can. Okay.
What is the reporting rate of the HIV self-testing intervention in Vietnam, and how many clients who receive self-test kit reported their result? Okay, so this is a voluntary thing. We cannot make it mandatory for people to report back self-test results. The WHO guidance on self-testing also says the same thing. But at the same time, I understand, where your concern is coming from. We do want people to get a confirmatory test done and then get them onto treatment. And so what we suggest as virtual interventions is that if you develop a robust follow-on system with your outreach workers or your case managers, and they have developed that kind of rapport with the client when they collected the kit or they ordered the kit online, then we have seen a very good success rate of about 80 to 90% of people do report back to that outreach worker or case manager when they conduct the test themselves. So although you cannot make it mandatory, and a lot of programs do face this issue of lower reporting, lower reporting of self-testing results, but we will need to put certain things in place. It also plays a, demand creation also plays a very important role here. You need to inform people that this is a screening test and you need to get a confirmatory test. And that kind of awareness will actually help people to come back and report their results so that they are linked to confirmatory testing as well. So it's like a journey, it's a process that we need to take. And we need to train our outreach workers and case managers so that they follow on with people, religiously and try to convince people or motivate people to report their results once the test is conducted. I hope that answers the question. What type of dashboard or virtual system do you use for the data management in ORA quick distribution and case management? So there are various things that have been tried out. A lot of programs have developed websites, which is like a comprehensive website which starts from risk assessment to appointment booking to the facility reporting the results on the back end, and then we can follow up with clients as well on that. And the same system and the same website has a back end which has a robust, like a dashboard or a system which generates automated reports as well. It has real-time data, which gives you like real-time dashboards. So that's one part of it. If you have the budget and the time to develop that kind of a platform, it's easily available. There are sharing platforms that are also available, like FHI 360 has a sharing platform called QuickRes, which is available at a very low cost, but you can use that for your country. You can adapt it to your country and use all the features. It has almost everything that you can do on an HIV program, including PrEP, HIV self-testing, ordering, index testing, etc. The other way to do it, if you do not want to go the website way or a web app way, is you can have an Excel-based dashboard as well. There are DHIS systems that are also available for dashboards. I know a lot of countries that have included virtual intervention indicators into DHIS too, and are working well with that. So there are various ways of doing it depending on your context for the country, your priorities of how you want to do it. You could also link, the data to your existing government program apps. Nowadays, all the government or the national programs have digital data, and you could kind of, redirect all your data into that app as well, so that there's one place where you're collecting data and not multiple apps or not multiple places. So there are various ways to do this. We can, depending on your country, if you want, I can definitely help you with this, and we can plan it in a better way. It needs some amount of planning and designing of a model for your country specific to your needs and preferences. How do you record clients who give fake names or don't give their names, and how do you verify them with reporting? So Nadika, we do not again collect major personal identifiers with virtual interventions. The only personal identifier that we would usually collect is a phone number, because that is how we would get in touch with the person. A name is not given so much importance. We understand that people give fake names all the time, and we would want to give them that choice, because there is this fear of stigma, discrimination, and being identified. And so we often tell them that you can give us your nicknames, you can give us any initials as well. It need not be your entire name. We also don't collect any other social identifiers like a social identity card or anything like that, just to make them comfortable to say that this is all going to be confidential. In terms of verifying for reporting, unless your country has like a unique identifying code system, we do not really verify people whether they have accessed services. There is a major issue of deduplication with regards to virtual interventions, which is something that we've been struggling with. Only because, you know, it's very, very, very difficult to deduplicate people on different platforms. I have multiple, you know, I might have an account on Facebook, I might have an account on Instagram as well as Grindr and Hornet and everywhere. And I might have a different name on every platform. So it's, you know, practically impossible to kind of identify me as one individual or deduplicate me across all these platforms. And so, you know, there needs to be some amount of you know, leeway that you'll need to give when you're implementing virtual interventions. We are still trying different things. Different countries are trying different things. We haven't found a one perfect way to identify or verify people or even deduplicate them. But we need to try newer things, and we need to keep trying and innovating. In what scenarios and situations would virtual interventions be not effective and face-to-face interventions would be better? I would say it depends. I would give the complete choice of self-care to the person who wants to access that service. So if the person wants to access it, they can, it will work. It will definitely work. I would say PWID population is one population where we've not had many you know, good documented case studies. It has worked. I'm sure Srinivas will have more to say when he talks in his presentation, but you know, we have had experiences, but not many with regards to PWIDs, primarily because, you know, they lack phones. They often sell their phones for the need of drugs. But having said that, I think we haven't really not, I mean, we haven't come across any such situation where virtual interventions would not work. It will have to be adapted based on your country context and the population that you want to reach. We will have to adapt the strategies and the approaches based on that, but we can definitely tweak things to make it work in your scenario or situation. Is there a plan to have a system that can be used or accessed by foreign nationals to know the locations of service providers of the countries they are visiting? I'm not getting this question correctly. Are you asking that any systems can be accessed by foreign nationals? You mean health facilities, or are you talking about just the locations of facilities? This question is not clear, Matthew.
Maybe we can come back to that. And I think, thank you so much, Purvi, for the presentation and for sharing all of the Q&A. So I think maybe we'll move on next to the panel discussion. Before we go to that, just want to make a note that there will be some interpretation. And so at the bottom center corner of your screen, please click on interpretation for English or Sinhala, depending on your language, as we have live interpretation for this session. So without further ado, I will hand it over to Nikki to introduce the panelists and to take it forward. Thank you. And thank you, Purvi.
Thanks, Matthew. So again, to all participants, welcome. We're gonna have this panel discussion, which is going to be nice and engaging, and also this is supposed to be, you know, like not very formal. You know, we're gonna make this as engaging as possible. So in the panel, you can see on the screen, we have a fabulous panelists today. But first, I'm gonna go to our friends from Path India, Srinivaji. So we have a question for you. Could you please explain the role of your organization related to virtual intervention in HIV programming, and also perhaps share the experience in implementing a cost-effective virtual outreach method?
Great. Thanks, Nikki, and thanks, Puri, for setting the tone in such a wonderful manner, as usual. So, you know, when we were starting the HIV program across the world, the initial focus was on people who were available in the physical spaces. The outreach was designed for people who were available in the physical spaces. As we move ahead and realize that there is a need to reach out to more people, we have this whole challenge of reaching out to the population that was in the virtual space. And for that, one of the key things, and there was also a question about pivot that we realized, is that we cannot bracket them. And this is purely from our experience, because, we did a lot of work for the last 7-8 years. There's been a realization of moving to the virtual population. So we had tried methods of gamification, having games with special coupons for those who did well. We had an artificial intelligence chatbot. We tried a patient management system. We tried a landing platform. And all of these have been successful. And this has been done by organizations like FHI, India HIV/AIDS Alliance, iTech, PATH, Humsafar Trust. So, in a way, I'm just carrying the load of all these people and the work done by them. And Purvi has been like one of those people who was the pioneers here. But what we realized very early on is that placing people into brackets of FSW, MSM, pivot does not work in the virtual space, because the identities are very transitional and very fluid. So for the sake of programming, we call them virtual vulnerable men, women, and transgenders. And that's the reason why when we looked at the pivot population, and just to respond quickly to that, we realize that it's not the traditional pivot population that we hear about in the HIV program that are in the virtual space, but it's more of population who are using drugs as recreational drugs or for sex. So their identity is different. They're not the traditional pivot that we know of in our HIV programs. So, as we moved ahead, we realized that we needed to also experiment with programs that are transitionable to the national programs. Because ultimately, all the programs that we run for HIV, be it domestic funding or funding from foreign sources or external sources, are limited, and we don't have the bandwidth of, say, an Amazon or Coca-Cola to be able to advertise our programs on the virtual space the way it needs to be done to attract more people. So with that in mind, we had a very simple program where we looked at a few outreach workers who could be placed within the system. And when I say the system, it means the national program in our country. And they would, through their networks, reach out with pre-scripted messages. The requirement was somebody who was quite familiar or decently familiar with the applications that are used, with the different the different networks that are there on the virtual space. And then these people started reaching out to their networks, and through their networks to other people. Yes, initially there was a lot of skepticism. People did not respond back. But slowly, over a period of time, what worked for us is the continuous dialogue with the government, where, there was one case where after a lot of counseling and after a lot of discussion, one person agreed to go to a testing facility. And there, as usual in the national program, because they're overloaded, the person was asked to wait. And that set us off thinking that probably we need to work at the service provision area also. And after nearly 6-7 months of training and advocacy, we were able to set up the testing centers that are friendly to the virtual population, which means that anybody coming with a coupon code or with a referral from the virtual outreach worker is fast-tracked for services. So we identified 4 or 5 such facilities in Bombay, trained the service providers, and there we saw a huge uptake once that happened. When these people realized that they were given priority at these service facilities, and they were provided a sort of a VIP treatment for testing, and the results were announced or given to them very quickly, we had a much larger uptake of services. So what helped us, of course, is a continuous dialogue with the national program, a program that we were able to synthesize in a very short period of time with very little and limited resources. And if we look at the data of that we've been doing it for now 3 years, what is amazing is that although, normally if you look at the virtual programs, your first click or your first reach goes into thousands or lakhs or millions. And from then, if we draw a cascade, we realize that the people who actually turn up, which what we normally call the conversion rate, is roughly around less than 1%, 1 to 2%, but it's very little, because finally of all the people who view your advertisements or who click on a page, those who actually go on to buy your services or get your services is a little number. So what we did is that we reached out to less number of people. We reached out to say 50,000 people through the messages, and our conversion rate has been nearly 18%. What was also alarming for us is that it's not just the HIV that was a problem for us. We were getting nearly 13 to 14% case detections. That means of all the people who were testing, 13 to 14% were positive. But we started getting nearly 12 to 13% syphilis positives also. And that set us off thinking that probably there is some amount of practices that make this population vulnerable to both STIs and HIV. And by simple logic, we know what those practices are. So we started to modify our messaging and start talking both about STIs and HIV. And we realized that the population liked it, in the sense that they related more with STIs, because STI outcomes for their, I would use the word sexual performance in the absence of any other word that I can think of right now. But the fear of an STI affecting their sexual performance was much more alive and immediate than the fear of HIV. So, those kind of tweakings, and so when we saw syphilis, we realized that we needed to treat them also. We just can't test them and leave them. So we, along with the with our service providers, we worked on a package which could help them to get treated for both STIs and HIV. These kind of modifications, both with the private sector and with the public sector, gave us some amount of visibility. I will not be vain by saying that we are changing the world here, but it did help us in reaching out to nearly 1,800 people in the last 1 year, of which 18% were positives, and we've put them on treatment also, because there has been a lot of rapport building with the counselor on a one-on-one basis. So and I was very proud and happy of our team, and I'm just speaking for my team here, when we were able to get 25 of these young men and women to come for a coffee date with all of us. So we called them to a coffee shop on a Sunday, because they were all working, and for the first time we were able to see these people face to face. It's not that they're dinosaurs, that they're not available, but the thing was that they are there, they're there. So we had a very lengthy discussion. We spoke to them about their needs and their thoughts. And what was enlightening for us also was that there was a lot of awareness. It's not like these people are totally unaware of what's happening, but the transition of knowledge to behavior was what was lacking. And what their need was a service which was non-discriminatory, which did not focus or continuously badger them with messages of HIV, and which they could avail of in their own space, in their own time. So they were not very happy with continuous reminders for HIV testing. So we said, we'll not do that. If you assure us that you'll get tested, we will not do that. We'll probably give you a fortnightly response or a question or things like that. And we had a very enlightening discussion, and we keep doing it with these people in small groups, in informal settings. And so, we don't obviously print any reports or photographs of this dialogue, but I realized that the need for adapting our interventions and being getting away from our own thoughts of traditional interventions is what is the need. Because as you can say, I am old, but most of these people that we spoke with were younger people. So I had to modify myself to their needs rather than the other way around, which normally happens in a physical space. So that's all for now from me, but I'm there for any questions. Thanks, Nikki. Thanks.
Thank you. So it's really interesting to hear the journey from scratch until you receive that thousands of result of number of reach. And also we're going to come back to you on the cooperation with the government and local service provision. I think that's very interesting. But we're going to move to our next panelist for now. I have a question for Indunil from Heart to Heart Sri Lanka. He is the virtual outreach worker. So Indunil going to answer in Sinhala, I believe, and we have the live interpretation function. So Indunil, maybe we of course want to know about the amazing work that Heart to Heart is doing. So maybe just a little introduction about your organization role related to virtual intervention for HIV programming, and more specifically, what kind of mechanism do you utilize for virtual outreach, and what aspects of HIV programming? So the Zoom platform is yours.
ලංකාවේ virtual outreach ක්‍රමවේදය ක්‍රියාත්මක වෙන්නේ IEC material මත පදනම්ව. ඒ කියන්නේ තොරතුරු අධ්‍යාපන sannivedana කියන ද්‍රව්‍ය උපයෝගී කරගෙන virtual outreach ක්‍රමවේදය ක්‍රියාත්මක වෙනවා. විශේෂයෙන්ම ලංකාවේ MSM, FSW, TG කියන component තුනම යොදා ගනිමින් virtual outreach ක්‍රමවේදය ක්‍රියාත්මක වෙනවා. අද දවසේ මම විශේෂයෙන්ම MSM component එක නියෝජනය කරන MSM ප්‍රජාව වෙනුවෙන් virtual outreach ක්‍රමවේදය හරහා HIV prevention program එක කොහොමද කරන්න කියන පිළිබඳව තමයි දැනුවත් කිරීම කරන්නේ. මුලින්ම අතන අපි virtual outreach ක්‍රමවේදය හරහා HIV නිවාරණ ව්‍යාපෘතියේ ලබා දෙන reach package ගැන හැඳින්වීමක් කරන්න. අපි reach package එක විදිහට HIV සම්බන්ධයෙන් දැනුවත් කිරීම සිදු කරනවා. ඒ වගේම STD සම්බන්ධයෙන් දැනුවත් කිරීම කරනවා. ඊට අමතරව අපි කොන්ඩම් එකක් නිවැරදිව පළදින්නේ කොහොමද කියන එක අපි දැනුවත් කිරීමක් කරනවා. සහ කොන්ඩම් සහ ලූබ්‍රිකන්ට් නොමිලේ ලබා ගන්නේ කොහොමද කියන දේ පිළිබඳව දැනුවත් කරනවා. වගේම කොන්ඩම් සහ ලූබ්‍රිකන්ට් නොමිලේ ලබා දෙනවා virtually. ඊට අමතරව PrEP සහ PEP ලබා ගන්නේ කොහොමද සහ ලබාගත සායන මොනවද සහ PrEP සහ PEP කියන්නේ මොනවාද කියන දැනුවත් කිරීම අපි සිදු කරනවා. ඊට අමතරව ටෙස්ටිං ගැන කතා කරා. විශේෂයෙන් ටෙස්ටිං කරගන්නේ කොහොමද, ටෙස්ටිං කරගැනීමේ වැදගත්කම කොහොමද. ඊට අමතරව HIV self testing විශේෂයෙන් ප්‍රමෝට් කිරීම අපි virtual outreach එකකට හරහා සිදු කරනවා. මීට අමතරව ඇත්තටම අපි මීට පරිබාහිරව HIV prevention program එකට පරිබාහිරව අපි Heart to Heart ආයතනය විශේෂයෙන් MSM ප්‍රජාව නියෝජනය කරමින් ඔවුන්ගේ නීතිය පිළිබඳව දැනුවත් කිරීමේ වැඩසටහන් ක්‍රියාත්මක කරනවා. එතකොට මානව හිමිකම් පිළිබඳව, අයිතිවාසිකම් පිළිබඳව මේ දේවල් ඇත්තටම දැනුවත් කිරීම සඳහා අපි virtually outreach වලට යොදාගෙන virtual outreach ක්‍රමය හරහා දැනුවත් කිරීමේ ක්‍රමවේදය ක්‍රියාත්මක කරනවා. ඉතින් ඒ හරහා ඇත්තටම අපි MSM ප්‍රජාව හරහා ජාලගත වීමක් සිද්ධ වෙලා ඉන්නවා කියන එක මට මේ වෙලාවේ කියන්න පුළුවන්.
Thank you. It's of course really interesting to hear how you utilize IEC materials for virtual outreach and to raise awareness about the HIV and sexually and other sexually transmitted disease. We have one more question for you. For now, we have one more question for you. So, as you know, as you do the community work at the ground level, you really work with the community. Are there any are there any challenges in doing the virtual outreach and engaging in new person online? And maybe by doing the community work, you have any tips on how to make it easier to deliver the service virtually?
විශේෂයෙන්ම අපි virtual outreach ක්‍රමය හරහා ක්‍රියාත්මක විවිධ සහ වැඩ කිරීමේදී අපිට ඇත්තටම challenges කිහිපයක් තිබෙනවා. එකක් තමයි ලංකාවේ තරුණ MSM ප්‍රජාව මුදල් අපහසුතා මත ජීවත් වෙන පිරිසක්. ඉතින් ඔවුන් ඇත්තටම ඩේටා කාඩ් එකක් පාවිච්චි කරනවා නම් අන්තර්ජාලය භාවිතා කරන්න. එතකොට ඔවුන් ඩේටා කාඩ් එක උපයෝගී කරන අන්තර්ජාලයේ විවිධ ක්‍රියාකාරකම් වල නිරත වෙනවා. නමුත් ඒ ඩේටා කාඩ් එක යූස් කරලා ඇත්තටම HIV සම්බන්ධ පෝස්ට් එකක් බලන්න ඔවුන් යොමු වෙනවා අඩුයි. ඉතින් ඒක ඇත්තටම අපිට ලොකු චැලෙන්ජ් එකක් විදිහට මේ වෙලාවේ මට කියන්න පුළුවන් අපිට අලුත් නිව් ක්ලයන්ට්ස් සම්බන්ධ කර ගැනීමේදී. ඊට අමතරව ඉන්ටර්නෙට් භාවිතා කරන්නේ නැති සහ ස්මාර්ට් ෆෝන් භාවිතා කරන්නේ නැති සහ ඔය ස්මාර්ට් ෆෝන් භාවිතා කරත් අධ්‍යාපන මට්ටමින් අඩු පිරිසක් ඉන්නවා MSM ප්‍රජාව තුළ. එතකොට ඔවුන්ට මේ HIV පෝස්ට් එකක් කියවීමේ හැකියාවක් නැහැ. අන්න ඒ පිරිස අපිට මේ virtual outreach ක්‍රමය හරහා අතර මඟ හැරෙනවා. ඊට අමතරව අපගේ outreach workersලා වැඩ කරන්නේ ඇත්තටම දිවා කාලයේදී. නමුත් social media app වල එහෙම නැත්නම් අන්තර්ජාලයේ අපේ සේවාලාභීන් ඇක්ටිව් ඉන්නේ රාත්‍රී කාලයේදී. එතකොට අපිට ගැටලුවක් තියෙනවා දිවා කාලයේදී outreach workersලා වැඩ කරනකොට රාත්‍රී කාලයේත් උන්ට කොහොමද වැඩ කරන්න කියන්නේ කියන. ඉතින් එතන ඇත්තටම ලොකු ગેප් එකක් තියෙනවා විශේෂයෙන් සඳහන් කරන්න ඕනේ. outreach workersලා ඒගොල්ලෝගේ virtual වැඩ දිවා කාලයේදී සිදු කරන්නේ. නමුත් ඔවුන්ට පිළිතුරු ලැබෙන්නේ මේ දේවල් වලට රාත්‍රී කාලයේදී. හැබැයි ඒ අවස්ථාවේදී සේවාලාභීන්ට රාත්‍රී කාලයේදී පිළිතුරු ලැබීමක් සිද්ධ වෙන්නේ නැහැ. වර්තමානයේ නමුත් අපේ virtual outreach workersලා ඇත්තටම ඉතාමත් අමාරුවෙන් දිවා කාලයේ රාත්‍රී කාලයේ වැඩ කරලා මේ සේවාවන් ලබා දෙනවා. ඒවයි සාර්ථක ප්‍රතිඵල අපි ලබාගෙන තියෙනවා. ඊට අමතරව ලංකාවේ තියෙන නීතිය සංස්කෘතියත් එක්ක විශේෂයෙන්ම තරුණ ප්‍රජාව විවාහ වෙන තෙක්ම දෙමාපියන් සමග වාසය කරන්නේ. ඉතින් එතකොට ඔවුන් දෙමාපියන් සමග ඉන්න නිසා ඔවුන්ට පුද්ගලික ලිපිනයක් නැහැ. එතකොට සාමාන්‍ය self test kit එකක් courier කරගන්නවා නම් කොන්ඩම් සහ ලුබ්‍රිකන්ට් courier කරගන්නවා නම් ඒ වගේ දේවල් ඔවුන්ගේ නිවසට ගෙන්වා ගැනීම හැකියාවක් නැහැ ඔවුන්ට. ඒ නිසා ඇත්තටම ඒ වගේ අවස්ථාවලදී ඇත්තටම අපේ අලුත් සේවාලාභීන් හොයා ගැනීම අපිට මගහැරෙලා තියෙනවා කියන එක මට වේලා කියන්න පුළුවන්. ඊට අමතරව මම මේ ක්‍රමවේදයේ ශක්තිමත් කරගන්න යෝජනා කරනවා. ඇත්තට විශේෂයෙන් virtual outreach workersලා මම මුලදී සඳහන් කරපු විදිහට ඔවුන් ඔෆිස් එකකට කොටු වෙලා එහෙම නැත්නම් එකම ස්ථානයකට වෙලා වැඩ කරන එක ඇත්තටම ප්‍රායෝගික නැහැ කියලා මම හිතනවා. උදාහරණයක් විදිහට අපි සේවාවන් ලබා ගන්න සේවාලාභීන්ට රාත්‍රී කාලේදී සේවාවන් අවශ්‍ය නම් අපි ඇත්තටම දිවා කාලේ රාජකාරියක් කරලා තේරුමක් නැහැ කියලා මම හිතනවා. ඉතින් ඒක නිසා අපිට පුළුවන් නම් ඇත්තටම මේ පැය 24ක කාලයක වුණත් සේවාව ලබා දෙන්න පුළුවන් ක්‍රමවේදයකට යන්න මම හිතනවා ඇත්තටම මේකේ සාර්ථක ප්‍රතිඵල ගන්න පුළුවන් වෙයි කියලා. අනිත් කාරණය තමයි අපි පුද්ගලයන්ගේ සේවා අවශ්‍යතාවය මත පදනම් වෙලා සේවාවන් ලබා දීම සඳහා කටයුතු කළ යුතුයි. පුද්ගලයාට සේවාව අවශ්‍ය දිවා කාලයේද රාත්‍රී කාලයේද කියලා නෑ. අපිට පුළුවන් නම් ඔහුට සේවාව අවශ්‍ය වෙලාවට ඒ සේවාව ලබා දෙන්න මම හිතනවා ඇත්තටම හොඳ ප්‍රතිඵලයක් අපිට virtual outreach ක්‍රමය හරහා ලබා ගන්න පුළුවන් වෙයි කියලා.
Thanks, Indonesian. So coming from Indonesia, there are some things, quite resemble to it's not the same, but it's totally different context. But some things are it's also happening, in my settings back in my country. So thank you so much for that comprehensive explanation about what's really happening at the ground level at the and in Sri Lanka. Next, we have our next panelist, Stephanie Pari from Grindr for Equality. They are the equality outreach manager. So really good to have you with us here, Steph. Joining from the US, it's midnight time in the US. So it's really a pleasure. Thank you. We know Grindr is one of the largest geolocation dating application for gay men and LGBTQI+ community. However, many may still not know about what is Grindr for Equality. And could you tell us what it's about and what really motivates Grindr for Equality to support community work, especially related to HIV issues?
Absolutely. Thank you, Nikki, for having us here. So Grindr for Equality is the company's social justice program, which is aimed at advancing LGBTQ safety, health, human rights around the world. We have different functions, which include help building features on the app that protect Grindr users and collaborating with global public health agencies and organizations to get the word out there on any kind of sexual health issues that are emerging. And throughout the years, we have acted as a bridge between our users and LGBTQ activists and organizations whom, we get input onto what is actually happening on the ground all over the world. And using that information, we feed that back to our users. And what I always tell folks is that I can't do my job without all of you, right? We want to make sure that you have a voice on the app. And we work in 4 different pillars, which is to educate, activate, fund the movement, and bring social justice to the app. And when we talk about educating our users, we're talking about our Sexual Health and Gender Identity Resource Center, which is currently in 60 different languages. And all of this has been in collaboration with community organizations and verified by activists as well, to make sure that folks that are reading this are also understanding what practicing safer sex looks like. What does it mean to even get tested for HIV or STDs, right? These are things that are important initiatives to coordinate with local folks on the ground for that. And when we talk about activation, right, to activate our users, we're talking about making sure that they're taking some kind of action, which that could be getting tested for HIV, signing up for PrEP, learning where they can find sexual health kits. And these things are all coming from organizations where we're able to send pop-up messages in the app to allow them to expand their reach. And one of the latest successes that I'd like to share, specifically in the US, is our partnership to distribute free HIV self-test kits that launched just this March. And this public health initiative is called Together Take Me Home. And it's with our close partners, Building Healthy Online Communities, Centers for the Disease and Control Prevention, and Murray University. And what we've done is within the app's main menu, as soon as you open it and you go into your site profile, you can actually, I don't think you can see it, but you can actually order free HIV home test. And that's something that anyone that orders it will receive it within a week or so. And it's an oral quick kit that you would swab in the gums, and the test shows a result in about 20 minutes. And our aim in the next 5 years is to give away 1 million kits. And even on the first day, the orders, the total number of orders was 10,000 kits throughout the United States. And, if your organization is working on distributing kits or is already distributing kits, HIV kits in your country, please do contact us. Like we'd love to figure out ways of supporting that work and figuring how to collaborate on this and many other HIV interventions.
Yeah. And talking about successes, so AppCom is part of the technical working group under a recently conducted PrEP survey that is implemented across 16 countries in Asia and Australasia. And therefore, we as the part of the technical working group, we request help from Grindr for Equality. And in the end, the survey concluded with more than 17,000 MSM participants, where more than 30% of those participants, more than 30% from 17,000 participants come from the Grindr for Equality platform. And and that's what I mean, that's a success. So we really thank, special acknowledgement to Grindr for Equality, because this survey is really important, is asking about the values and preferences of community. What do they think about the, what do they choose, whether it's oral PrEP or it's injectable PrEP. It's one of a kind for at least for the Asia Pacific region. So yeah, we really applauding Grindr for Equality for that. which come to my next question. Many LGBTQI+ and gay men-led organizations really want to expand their reach by using Grindr. How can they actually connect with Grindr for Equality for any collaboration? Is there any recommendation on how they should use the platform to help promote information and service related to HIV in their country? Any tips, perhaps?
Absolutely. And thank you for mentioning the survey, and thank you more than anything for trusting us to be one of those platforms that you use to, gather that important information. I always tell people I am here. I am the person to contact for any type of messaging on the platform. And when I tell you I am on my phone 24 hours a day, you see me here, right? You will get me when you need me. Grindr is open to working with community organizations all over the region. It's a commitment that we have, a commitment that I have personally. And we want to really focus also on the groups that are providing services outside of the main cities. We always know that we have these concentrations, but we want to make sure that we're getting this information to as many people as possible. When it comes to working with us, I say email us. It's the easiest way to get in contact at equality@grindr.com. And Nikki, please feel free to share this with anybody you need to, and as well as any of the participants that are here, equality@grindr.com. One of the things that we promote at G4E, Grindr for Equality, is the free messaging through the in-app services. And that can be monthly or quarterly or once in a while, depending, on the type of work that you're doing. This is where we come into this one-on-one kind of conversation of what is your goals, what's the community you're trying to contact, and what do you want to learn from the community as well. And it's one of my favorite parts because I really get to see how each group is working with either virtual interventions or also any other kind of programming, right, that can also intersect. So for example, we've done a lot of messaging in terms of like peer support groups, especially during COVID times where you really can't see each other in person, then let's come online, right? Any kind of helpline. So when you are getting tested and you don't know what to do when you get a positive result, right, you have someone online to be able to support you and get you to the resources that you need. And we want to also promote any kind of minority languages. We know that a lot of countries in this region have various languages, so sending it just to one language in particular, we can actually send that same messages to 4 or 5 different languages at the same time, depending on how the user has their phone set up, right? So you want to make sure that we're easy to reach, and more than anything, being able to provide that platform, because the platform is yours.
Oh, thank you. So everyone make a note, equality@grindr.com. equality@grindr.com. Okay, so thanks, Steph. So last but not least, of course, we have one question for Purvi due to in respect of time. So Purvi, there was ample support for virtual intervention for HIV services. Like we see avant-garde demand creation digital campaign, those campaigns utilizing high-end community influencers and efforts to reach, to record a client journey from at the time when they start having awareness to the clinic doorstep. These are all, require a lot of funding. Right. However, in recent years, we saw funding support for online-based initiatives are actually declining. Some would argue that it is hard to measure impact, or is it worth it for the return on of investment? So, in your opinion, how far will online intervention play a pivotal role in HIV programming going forward?
Thanks, Nikki. That's a very interesting question. I'd like to start by saying that, virtual interventions is not like a periodic intervention, which is currently being done only to mitigate impacts, etc. This intervention needs to be integrated into the national program or the physical program that has been happening for decades. this is the new way people want to be contacted. This is the new way people want to access services under the whole self-care option that we need to provide to people. With regards to funds, I think they're not declining. I would say that a lot of countries have already done their initial investments on their web apps or the major investments in terms of innovations. And now the costs have reduced in terms of the input that they need to put in every year because the systems are in place. The countries who are new to virtual interventions will definitely need an initial investment or an initial fund allocation to do that. And I think the Global Fund grants that are the cycles that are going on currently are the perfect way to start integrating virtual interventions into larger programs, because then ultimately that will be transitioned to the national program as well. So I don't think the funds are declining, but I would say that they're just being used in a more effective manner. They are people have understood, or people now understand what kind of approaches they want to implement, and then they are budgeting, or even the donors now understand virtual interventions, because a lot of awareness through WHO and UNAIDS has already happened to the donors as well. And so they know, what is important, what kind of approaches would work in a country, and accordingly the fund allocation is done. So I would say that it's not decreasing, but rather it's being used more effectively and efficiently. And I think which is like not a bad thing to do. It's always good to plan your resources and use them in a more efficient manner. Over.
Thanks, Purvi. Okay, I think we still have more time. I want to come back to Srinivasji, where I still have one more question for Srinivasji, where it's as mentioned earlier, we really wanted to know how the working relationship with government would be. So integration of virtual intervention into the national program or existing facilities has always been a challenge. How did PATH India think of working with the facilities, and what are some of the challenges faced, and how did you overcome them?
So if you look at it from the perspective of the government, and this is something that all of us have experienced through our work, what is it that they require? They require transparency of data. They require systems which will ensure data security. Because ultimately they're the government, they're responsible for the overall data security, and they require a free flow of information between what somebody is doing and what the government is doing, so that there is no duplication. So basically deduplication, or ensuring that we're not reaching the same people. So what we did is that, first of all, we placed this person in such a way that the person was available for any talk that the government wanted to have as and when required. Secondly, we ensured that in the initial phases, we said the service provision will happen at the government facility, provided you are able to bring the government facility up to speed so that the virtual population can access. The kits are the same. I mean, they might be a little different. The only challenge that the population had was in accessing. So we said, you bring up your facilities to speed, and we will refer them, so that you are sure that the people who are going to your facility are actually going, and we are not throwing up random numbers. And finally, whenever we used to on a periodic basis, so we initially started with fortnightly and then monthly, now it's quarterly. On a periodic basis, we would go to them with whatever information we had, and present that information. So essentially, my learning has been that being transparent and being open to the work that we're doing built an amount of trust that the government realized that they're doing work there to help us, and they're not doing something parallel. While doing it, the benefit for us was that in terms of budgets, we got a space free of cost, which was one of the biggest hindrances in a place like Bombay, which is very high in real estate. Secondly, we got these new facilities, government facilities, which were revamped. The facility service providers were trained and sensitized on how to reach and how to talk to this population. And they even painted up the place and made them a little nice to look at. So we got that in return. So I think that it's, you know, always good, because at the end of the day, if you want to reach scale, governments are the best people who can reach scale. None of us has the bandwidth to be able to reach our programs to scale. So for me, the three key mantra was, you know, constant dialogue, transparency, and ensuring deduplication.
We gotta remember those mantra. Chatting. Thank you, Srinivasi. I think in the chat box we have a question for Indonil. Yeah, so let me read it out. This question is from Kanti. So Indonil, this is a question for you. Is it always the MSM community is in poor socioeconomic class? I feel it cannot be. What are the services heart-to-heart doing for other socioeconomic groups? Who will be targeting those MSM from upper socioeconomic group? Hope it's quite clear. Yeah.
ඔය ඇත්තටම මට ප්‍රශ්නේ තේරුණා. එකක් තමයි ඇත්තටම MSN ප්‍රජාව විතරක් නෙමෙයි ලංකාවේ ආර්ථික අපහසුතාව ඉන්නේ FSW විශේෂයෙන්ම TG ප්‍රජාව විශේෂ ආර්ථික අපහසුතාව මැද තමයි වුන් ජීවත් වෙන්නේ. ඊළඟ කාරණය තමයි ආර්ථික අපහසුතාව නැති පුද්ගලයන්ොත් ඇත්තටම අපේ කණ්ඩායම තුළ ඉන්නවා. විශේෂයෙන්ම ඒගොල්ලෝ අපිට භෞතික වශයෙන් අපේ සර්විස් ලබා ගන්න සම්බන්ධ කරගන්න බැරි පුද්ගලයා. ඉතින් ඇත්තටම ඒගොල්ලෝ මේ virtual outreach ක්‍රමවේදය හරහා ඇත්තටම සම්බන්ධ කරගන්න පුළුවන් හැකියාවක් අපිට ලැබිලා තියෙනවා. මම හිතනවා ඔබගේ ප්‍රශ්නෙට පිළිතුරු ලැබෙන්නේ නැති කියලා.
I think interpretation is not working. For interpreter, maybe you could give the highlight or the summary of Indonil's response.
Yes, we can hear you.
Okay. ඇත්තටම ලංකාවේ MSM ප්‍රජාව විතරක් නෙවෙයි මූල්‍යමය ආර්ථික අපහසුතාව එක ජීවත් වෙන්නේ විශේෂයෙන්ම FSW සහ TG PWID මේ කියන හැම කොට්ටාසයක්ම ඇත්තට උදාහරණයක් විදිහට TG ප්‍රජාව ඇත්තට MSM ප්‍රජාවට වැඩි ආර්ථික අපහසුතාව මැද්ද තමයි ජීවත් වෙන්නේ. හැබැයි මේ virtual outreach ක්‍රමවේදය හරහා ගත්තාම අපිට මේ විශේෂයෙන් MSM component එකේ outreach workers ලා සම්බන්ධ වෙන පිරිස් එක්ක අපිට බැලුවාගෙන් පස්සේ දැනගන්න හම්බෙලා තියෙනවා. ඒ කියන්නේ ආදායම අඩු පුද්ගලයන් වගේම අපි නිකන් කියනවා පොස්ට් ලෙවල් එකේ කට්ටිය කියලා කියනවා. ඒ වගේ කට්ටියවත් හම්බෙලා තියෙනවා. ඒ නැත්තේ නෑ. ඉතින් මේ දෙකොල්ලම ඇත්තටම අපිට මේ virtual outreach ක්‍රමවේදය හරහා රීච් කරන්න ලැබිලා තියෙනවා.
Thank you. Thank you, Indonil, for the response. Actually, I still have some more questions, but you know, in respect of time, I think we have to wrap this up. But before we wrap this up, I want to ask to all panelists for a closing remark, related to virtual intervention for HIV services. So maybe we can start with the we can backwards the order. Maybe we can start with Purvi. Closing remarks, please.
Thank you. I think this was a great opportunity, Nikki from APCOM and AFAO. I would like to thank everyone for their time. I think my closing remark would be, we need to give self-care options to our populations. It's time that we leave it to them, what they want to access, how they want to access, and where they want to access. We just need to provide options to them as as program people and just, give them the required information and the options to access those services. So self-care, I think, is the new word that we should be all looking for. Thank you.
Awesome. Thank you. Steph?
Thank you, Nikki. I want to thank everyone that's here, the panelists, for sharing your perspective, your knowledge with everyone. And more importantly, I want to thank all the organizations and especially the peer navigators in attendance who are providing, this important care for our community. The efforts that are being done are key. And I really do invite you all to use the platform for your resources and, really just join us in building that joy and connection and liberation for the LGBTQ community. We appreciate the contributions that are being done in this region, and we want to continue working together.
Thank you. Indonil?
ඇත්තටම ඉදිරියේදී දැන් අතර බොහොමයක් දේවල් සිද්ධ වෙන්නේ virtual ක්‍රමවේදය හරහා විශේෂයෙන්ම MSM තරුණ ප්‍රජාව ඔවුන්ගේ අවශ්‍යතාවයන් සපුරා ගන්න සම්පූර්ණ කර ගන්න මේ virtual ක්‍රමවේදය භාවිතා කරනවා. ඉතින් HIV නිවාරණ ව්‍යාපෘතිය තුළ උනත් ඇත්තටම මම විශ්වාස කරනවා virtual ක්‍රමවේදය හරිය නිවැරදි ආකාරය කියන්නේ මේ තියෙන ගැටලු අඩුපාඩු නිවැරදි කරලා සහ පුද්ගලයන්ගේ සේවා අවශ්‍යතාවය මත අපිට සර්විස් එකක් දෙන්න පුළුවන් ක්‍රමවේදයකට යන්න පුළුවන් නම් HIV prevention program එකේ මීට වැඩිය සාර්ථක ප්‍රතිඵල virtual outreach ක්‍රමය හරහා ගන්න පුළුවන් වෙයි කියලා මම විශ්වාස කරනවා. බොහොම ස්තුතියි.
Thank you. And last but not least, Srinivasji.
Thank you to the panelists and to AppCom for this wonderful opportunity, and to WHO Purvi for giving us insights. For me, I would say one single thing from my side that I learned is to move away in our heads from calling these people FSW, MSM, PIVID, and transgender. They are vulnerable men, women, and transgenders, and their identities are not the identities that we have in our heads of traditional HIV outreach approaches. We need to move away from that and look at these people. And, the moment we start looking at these people and not as FSWs, MSMs, and PIVIDs and transgenders, we'll realize that their needs are different and their requirements are different. Their service points and service uptake requirements are very different. And then I think we'll be able to devise and design our programs appropriately. Thank you.
Thank you. And adding to that, specifically tailored approach to reach them need to be really defined. And don't forget the 3 mantras to make cooperation with the government. Okay, so those are the closing remarks from the panelists, but we're not going to be done yet because we're going to hear reflections and way forward from Mike Merrigan from the AFAO team, but so I should give the platform back to Matthew, I guess.
Yes, great. Thank you so much, Nikki, and to all the panelists for sharing your time and expertise, and then also all the attendees. I know we have over 65 attendees, so thank you for your time and effort. And I know you're all busy in your lives. So I will hand over to Mike for some closing remarks and reflections. But yeah, thank you again to everyone.
Yeah, thank you very much, Matthew, Nikki, and other panelists. It's really been a very great and high quality webinar today. I'll just use the closing remarks to try to summarize some of the main take-home messages from each of the panelists. We started off with Purvi Shah from WHO and UNAIDS, who talked about virtual interventions, including telehealth, and a number of services that are now being delivered online or at a distance. She mentioned the convenience benefits for many people, including key populations who experience stigma and discrimination and would prefer not to have to attend health facilities. Virtual services, there's so many different services that can be offered virtually, Purvi said, as long as they are really enough planning and goes into the delivery and how they'll be set up. And also, obviously, the logistics are important as well if we're doing things like distributing test kits from virtual interventions. Purvi also mentioned that demand creation can be done very cost effectively using virtual platforms, and virtual case management is also being used effectively, particularly for people living with HIV support during COVID-19 in Nepal. Purvi also mentioned that WHO has and UNAIDS have released a new policy brief on planning and implementing virtual interventions. So we really encourage you to check that out, because there's some real practical guidance there, including some examples. And we did discuss in the chat and in the follow-on discussion how there's still some difficulties in deduplicating individuals reached by virtual interventions. And Mr. Srinivas from Path India talked about their excellent experience doing virtual outreach work in India. Some of the keys to success there were the continuous dialogue with government, which was really important. People were convinced to go to HIV testing in a way that was friendly for virtual service recipients. And a really interesting initiative there, where they actually had people who were coming to the services through the virtual platforms were given fast track access to services like testing. And this resulted in a really big uptake of services. So that's a really nice feature, is to give priority to people who access the services virtually when they actually visit the services in person. They had 3 years experience with limited resources. In the beginning, they were only able to get 1 to 2% of those clicking on a page to go and get HIV services. This increased up to about 18% when they used more targeted approaches, and they're able to get very good yields of around 13 to 14% case detection through the virtual platforms. And they also found that STI services were a very good hook for attracting people into the services. Then we heard from Indanil, who's the manager, the outreach manager at Heart to Heart in Sri Lanka. In Sri Lanka, virtual outreach has become a very important component of the MSM HIV prevention program. Indanil mentioned that young MSM often have financial difficulties accessing virtual platforms given the cost of data, and that some low education can also be a barrier with things like literacy. But virtual interventions are proving very popular. Even virtual outreach workers, they don't need to work only at daytime. Virtual outreach can be done at different times that are more suitable to clients. And he mentioned that virtual outreach workers don't even need to work in an office setting. They need more flexible working arrangements with a view to providing more comprehensive services around the clock. He said we need to consider preferences of individual clients, and they've had a lot of success reaching MSM of different socioeconomic status there in Sri Lanka through the virtual platforms. Then we had a very interesting presentation from Steph from Grindr for Equality, and thank you very much, Steph, for joining our webinar today. Grindr for Equality aims to improve the health and safety of LGBTIQ populations. They often act as a bridge between organizations and activists and feed the information back to the platform users. They have a real focus on bringing social justice to the app and include extensive resources on safer sex and sexual health, which are translated into several languages on the platform. They also have a very interesting partnership at the moment to distribute free HIV test kits with the US Center for Disease Control and Prevention, Emory University, and other partners. And they have a goal of distributing about 1 million test kits to give away in the US. And it was a very successful launch, and they distributed about 10,000 kits on the first day. And Steph has mentioned that the program is very interested in collaborating with other organizations. So I'm sure those of you will take that up. And thanks also for the vote of thanks from Nikki for the great work that Grindr is doing. So I think that's all for me. Thank you, Matthew and team.
Great. Thank you so much, Mike, as well as all of the panelists today. So we'll also share out the presentation and a recording from today's session with everyone who attended, as well as those who are unable to attend to watch later on. So yeah, once again, thank you all so much, and hope you have a great day.
Thank you so much, everyone.
Bye-bye. Thank you.
Bye.
Thank you.
Bye.
Bye.
Thanks, Selamat Pagi. Bye, Purvi.
Thank you.
Bye,
Bye,
Mai.
everyone. Thank you
Bye-bye.
so much.
Indonesian, thank you.